So hi, my name's Paul Ursell. I'm an NHS consultant and I work at Epsom and St Helier Hospital, which is just south of London in the UK. So in our unit we do about 2,500 cataracts a year. I teach junior doctors, so I take them through their first cases and then get them over the hurdles as they go forward to becoming experienced surgeons. And then I usually in the NHS get to do the difficult ones that they don't want to do. And then in my private practice I do a broad spectrum of all different types of cataract patients. About a third of my patients are having premium lenses with multifocals intolerance. Yeah, so we've been using Malyugin rings for 7 or 8 years now. We start off with 1.0 and now we've moved to 2.0. There's not a huge amount of difference. I think the 2.0, the scroll's a little bit wider, which makes it easier to engage and disengage without causing any iris trauma. Occasionally, if your scrolls are very tightly adherent to the edge of the pupil, when you come to take them off and disengage, you can traumatize the iris. We're getting less of that, I think, with the 2.0, but it's difficult to evaluate, but it certainly feels more comfortable. So we wanted to look to see whether there was a difference between Malyugin rings and iris hooks. So we have two groups of surgeons, one are very keen on using iris hooks and one are very keen on using Malyugin rings within our unit. And so we did an analysis of our Metasoft database. We had about 9,500 procedures, of which there's about 425 small pupil cases which needed expanders, about 4.5%. We had 315 Malyugin rings and 95 iris hooks. And what we found was that the main difference was the amount of time it took to do the procedure. So if you had a standard case, it averaged out about 16 minutes in theatre. If you had Malyugin rings, you added 4 minutes onto the case on average over the 300 plus that we had. And we could look at the difference between each surgeon. So a surgeon who was an average 20-minute surgeon was going up to 24. A 15-minute surgeon was going up to 19 minutes. So we looked at that. And the same thing we did with the hooks data, but they were going up 14 minutes. So it's an extra 10 minutes to do hooks compared to Malyugin rings. We also found more PC ruptures in the hooks group. And then when they did have a PC rupture, it just took them longer to manage the PC rupture when they had hooks compared to when they had Malyugin rings. The big difference was the amount of time. So if you had 2 cases on a list of 7, you're adding 20 minutes, half an hour to the length of the list, which is significant in high volume units like ours. Whereas with Malyugin rings, you're not. And that means the list doesn't overrun and you don't have problems with scheduling. One of the things that all surgeons struggle with is trying out new techniques and evaluating new ways of doing a procedure which they're very comfortable with. So most of us have a technique that we've honed over many thousands of cases that we know works for us. And we're all a bit different, we all try it differently. But then when a new technique or a new instrument comes along, people find, I used that and I didn't like it. Well, is that a good way of evaluating things? So we now have a protocol that I use with my junior doctors to change your technique. So if you're looking at a new instrument or a new technique, first thing, it's a 3-stage process. The first thing you do is you look at the sort of academic results side of it, thinking, is this a good thing to do or not? If you think, yeah, you know what, I think I like the look of that, I think that definitely would be an improvement, but I want to implement that in my practice, and then people use it and I didn't like it. The problem with that is the learning curve, because you're very comfortable with your old technique. This new technique you won't be comfortable with by default. So what I say to people is choose a number, 10, 15, 20 times. So you're going to use a Malyugin ring, for example. And then say, I'm not going to give up until I've done it 10 or 15 times. That means I'm going to get over the learning curve. I'm going to teach myself how to do it. Then I'm going to become comfortable with it. So after 15, 20 times, you can then say, right, I now know how to use this new instrument, Malyugin ring, for example. And then I go back to my original premise, look at the academic evaluation I made and say, now I've used it, I've got over the learning curve and I'm now using it. Is it what I thought it was? Yes, it is, or no, it's not. And then you can reevaluate it. But what it enables you to do is have a very comfortable, secure technique, but then you can improve on it and move it forward and take it to the next step, which is a very useful skill for us as surgeons to learn.